Not every poisonous mushroom will kill you, but that's setting an awfully low bar for safety. The mushrooms that cause severe gastrointestinal distress, without the liver and kidney damage of amatoxins, still send thousands of people to emergency rooms every year, still require hospitalization and intensive medical intervention, and still create situations where diagnostic uncertainty means treating every case as potentially fatal until proven otherwise. Chlorophyllum molybdites, the green-spored parasol mushroom, holds the dubious distinction of being the most common cause of mushroom poisoning in North America. It grows prolifically in lawns and parks, often in large fairy rings that make it seem abundant and therefore safe to people unfamiliar with mycology. The toxicology involves compounds that cause violent vomiting, severe diarrhea, and intense abdominal cramping, symptoms dramatic enough to send people to the ER convinced they're dying, even though the mushroom rarely causes the organ damage seen with amatoxins. Jack-o'-lantern mushrooms from Omphallotus species and certain Boletus varieties round out the common culprits in gastrointestinal mushroom poisoning. These contain various toxins that irritate the digestive system severely without necessarily causing systemic organ damage. But here's why these non-fatal poisonings matter medically. Severe dehydration from prolonged vomiting and diarrhea requires intravenous fluid replacement. Electrolyte imbalances can cause cardiac arrhythmias and other serious complications. The violent vomiting creates aspiration risk if stomach contents enter the lungs. And elderly patients or those with underlying health conditions can deteriorate rapidly from the physiological stress. The diagnostic challenge in emergency room settings makes every mushroom poisoning a high-stakes situation. When a patient arrives with gastrointestinal symptoms hours after eating wild mushrooms, physicians cannot immediately determine whether they're dealing with relatively benign GI toxin species or the early phase of deadly amatoxin poisoning, both present initially with nausea, vomiting, and diarrhea. The critical difference, whether the liver is being destroyed at the cellular level, won't become apparent for another day or two. This diagnostic uncertainty drives medical decision protocols. Every mushroom poisoning must be treated as potentially fatal until species identification or clinical course confirms otherwise. That means aggressive supportive care even if symptoms seem manageable. It means monitoring liver enzymes and kidney function regardless of initial presentation. It means poison control center consultation and potentially toxicology involvement. And it means the patient experiences the anxiety of not knowing whether they're facing a miserable 24 hours or impending organ failure. Patient experiences of non-lethal mushroom poisonings consistently describe them as among the worst acute illnesses they've endured. The combination of uncontrollable vomiting, severe cramping, and diarrhea lasting 6 to 24 hours creates profound physical misery. The fear and uncertainty while waiting to learn whether symptoms indicate something more serious adds psychological torment. And the realization that they did this to themselves through an avoidable mistake leaves lasting trauma. The medical resource utilization for these poisonings is substantial even when they don't cause deaths. Emergency room visits, laboratory testing for fluid administration, monitoring, and potentially overnight observation consume healthcare resources and create significant medical bills. From a public health perspective, preventing these minor poisonings through better education and reduced foraging would save considerable healthcare costs, while sparing people genuinely awful experiences.